Our next speaker and the last speaker for this session is again Professor Razavi. He's going to talk to us about the below-the-knee interventions, and hopefully we'll have a couple minutes for questions and answers. I was told by Dr. Shammari to advise you to go and...
Very much. So I'm going to take an entirely technical approach to this talk because a lot of questions are, how do you do this, how do you do that, what are the strategy for treatments? Can you guys display this? Thank you. Disclosures again. So obviously, in terms of treatment of patients with critical limb ischemia, the objectives of treatment for the limb are pain control, management of ulcer and gangrene, infection control, and those obviously have protocols for them, revascularization when needed, and amputation. Actually, a lot of people try to say avoid amputation. Amputation is actually a viable option for a lot of patients with critical limb ischemia, especially those who are not ambulatory and those who have severely other comorbid conditions. The idea of avoiding amputation is appropriate only in appropriate patients. Endovascular treatment of critical limb ischemia or below the knee is a complex problem. It's frequently multiple vascular beds are involved and they need to be treated. The typical scenario is treatment of more than one lesion or more than one bed or more than multiple lesions in a single bed. And the outcome is related to multiple anatomic and physiologic parameters, not just to lesion length or the modality of the treatments. Indication versus outcome is one of the important ones. And again, I used the analogy of cancer in the previous talk. This is the same. It's sort of like breast cancer. Breast cancer, as we all know, it's 5 different diseases. It's not one. Critical limb ischemia, it's not a single disease. It's multiple diseases. If you look at patients with claudication, rest pain versus tissue loss, the survival, limb salvage, recurrence of symptoms, progression of symptoms, primary, secondary patency, reintervention rate, and maintenance of independence decrease as you go down. So there are differences between Rutherford-Becker 5 and 6, certainly between Rutherford-Becker 4 and 5. Although we put both of these into the critical limb ischemia patients, they're not the same group of patients. Their outcomes are very different whether you do surgery or endovascular treatment for these patients. For example, if you take a simple CLI patient with below-the-knee lesion and treat that, and you have a same patient with diabetes or versus renal failure, the outcomes are different. If you look at various trials, Rutherford-Becker 4 patients are about 5 to 15% of the patients, so they're not as common. 50 to 70% are Rutherford-Becker 5, and about 10 to 20% are Rutherford-Becker 6 patients. Those are the patients who have gangrene. The treatment objectives in those Rutherford-Becker 6 patients are different than 5 patients. 5 is limb salvage, 6 50% of those patients, regardless of what you do, end up with amputation. So the treatment would be that the amputation site heals, and then you focus on the patient itself. Modification of risk factors, things we talked about in the previous talk. Now, in terms of distribution of disease in patients with critical limb ischemia, 5% involve all segments, including aortoiliac all the way down to the leg, to the tibials. 3% only have aortoiliac disease. 1% have aortoiliac plus femoral disease. 4% have femoral disease only for reasons that we all understand, because femoral disease is duplicated. That's why it's not very common. 30% have fempop and posterior and tibial disease, and about 50% have, or 55% or so, have tibial disease only. Popliteal. This latter group has a poorer outcome than multi-segment disease. So if your patient has SFA and tibial disease, actually those patients do better than the patients that have isolated tibial disease. Now, endovascular strategy has to be, to the extent possible, revascularize every revascularizable territory and lesion. That's what we do in our lab. Even if we establish in an angiosome concept, let's say some patient has a first toe ulceration, and you reestablish anterior tibial into dorsalis pedis or posterior tibial into the plantar arteries of the foot, we go after the other one. We do not, in fact, I personally go after all 3 until we fail. And our data that was presented not too long ago is in press right now, shows that when you revascularize more than one territory, regardless of the angiosome concept, that those patients do better. The time to recurrence and time to amputation is much longer in those patients that you treat multiple vascular territories. Remember that the efficiency of blood transfer after an endovascular intervention is far less than a bypass conduit. A bypass conduit to a single below the knee artery or even foot distributes the blood a lot better than any endo. So that's why you need to revascularize as many vessels as you can. Choice of tibial revascularization depends on the patient's anatomy and the symptoms. Again, angiosome concept that will be discussed later by a different speaker. And now let's talk about toolbox. Access is very important, support catheters, wires, balloons, and things of that. So this is critical in your success rate. That's why the endovascular interventions below the knee have better technical and long-term outcome in the hands of experienced people than those who don't. Because partially, obviously, experience and partially the selection of tools and familiarity with tools. Access, antegrade versus retrograde. I prefer antegrade in the common femoral. The problem with patients in the United States is that a lot of them are obese. And it is very difficult to get access into the common femoral artery in the antegrade fashion. And we have to go retrograde because it is almost impossible in obese patients to get access. Or if the SFA is occluded to the top and is a flush occlusion, you may not have enough room. Pedal access in our hands, we do it when antegrade crossing fails. So we don't do it as a primary access. A lot of labs do that. They access primarily from the pedal access. We don't. We go from above, and if that fails, then we go into a pedal access. My preference is dorsalis pedis because it's easier to get into them. Posterior tibial also. I try to avoid high perineal access. It's not a compressible area. You can get compartment syndrome. In fact, you will get compartment syndrome. There's a paper just published in JVS that showed a 50% compartment rate in those patients with perineal access. Low perineal is compressible. High perineal is not. I have learned that the hard way. We try to avoid that. Pedal loop, transcollateral, these have been discussed. They have been written in the literature. They're very useful. They're interesting concepts. You need to be familiar with them, especially the pedal loop, because in diabetics, you really need to get the flow going into the foot. And sometimes you can avoid revascularizing multiple antegrade arteries if you get a good pedal loop access. I always access the foot with under ultrasound. Anywhere under ultrasound. For us radiologists, it's much easier. It's a second nature to us because we always work with ultrasound. So hand-eye coordination comes in second nature to us. I don't do an angiogram to see where a vessel is to access it. In fact, we have used ultrasound to access a totally occluded dorsalis pedis to recanalize the popliteal artery. So the objective is not to get antegrade flow into the dorsalis pedis. The whole thing is occluded, including anterior tibial, but it was to recanalize a popliteal artery in a retrograde fashion. You can get it with ultrasound. It's not that hard. We always like to have the tip of our sheath or guide as close to the lesions as possible. For example, here's an angiogram on a patient, as you can see here, with a distal anterior tibial occlusion that we're trying to recanalize, and the tip of the sheath is sitting right here in the popliteal. Okay? So we like to get things as close to the target as possible. That reduces the amount of contrast you use when you do angiogram. It gives you better torqueability. It gives you better forward push. And it just makes life easier for you. Support catheters, multiple out there. I used to use balloons as my support catheters because the balloon technology is now very good for below the knee. It's okay when, for its lesion like this, it's all right. You can put just balloon. It saves you one exchange. But if you have a lesion like this is a posterior tibial complete occlusion with a hint of plantar artery, lateral plantar artery coming in. And if it's very densely calcified, you need to use a support catheter. And we have very great support catheters out there from multiple companies that allow you to do this. Wires are critical to success below the knee. My preference are 0114. And the reason for that is because there are more platforms available on 14 wires than there are on 01H. A lot of our European colleagues and some of the Americans actually like 01H for reasons I understand. But if you are an 018 system and you need to use a coronary balloon, you're out of luck. But if you're on an 014, there are great coronary balloons available that you can pull and use to save you trouble. Re-entry devices are all 014. A lot of the coronary stents are 014. In fact, all of the coronary stents are 014. So my preference is 014, especially nowadays where we have fantastic 014 wires available for below-the-knee work. Specialty wires, there are a lot of CTO wires. Some of those companies out there have them. I suggest that you guys visit them. Personally, I use Abbott wires, but they're great wires by Cook and by Bard and others. We have finesse wires at our disposal. Those of us who both work below the knee and in the head, believe it or not, we use a lot of neuro wires for finesse work below the knee. Something, for example, like this. Here's a lesion, that anterior tibial stenosis up there that you can see at the origin of it. It's not that easy to cross it. It's a very dense calcified lesion sitting there. This is a very easy crossing for one of the neuro wires because you can easily manipulate it across those stenoses and not go subintimal in those lesions. And then you can exchange. You can exchange your workhorse wire with a good backbone that you can then advance your systems on it. Something like this, neuro wires will not do you any good. You need CTO wires. You need some of those tough wires. And then what happens is when if the tips are not robust, we've seen all of this. All of us have seen this. Now, good news is that now there are wires with very robust tips from both Truma and Abbott that allow you to go through these things and still maintain the shape of the tip of the vessel. Now, some examples. For example, here's a patient with a first toe ulceration. As you can see, second and third toes have been resected up there. The surgical clips are still there. And this patient now has osteomyelitis of the first toe. So we need to reestablish flow to treat the infection. More than likely, this patient will end up with amputation of that first toe also because the bone is involved. But the surgical site needs to heal. So you need to have good flow into that foot. Now, the strategy here is that very poor flow as these diabetics. As you can see, incomplete arch in the foot, but a very nice lateral plantar target down there. So I tried to actually do this through a pedal loop, which is not as easy as it sounds. If you go to all of these, the movie here. Now, there are different ways you can use it. One of my favorite techniques is actually to loop the wire, and I use some of the coronary wires in these cases. And as you can see, the tip of the wire is sort of looped around the tip of my support catheter. Can I just push this? Will it go or not? All right, forget it. Anyway, so there are a couple other movies, looks like they're not going to play, that I just want to make sure that you guys see some of these so you feel comfortable with interventions in the foot. A lot of people are uncomfortable who do CLI work. If that lesion was higher up in the SFA, popliteal, anterior tibial, many of you would not even think twice about doing those. When it gets down here, people sort of sometimes worry about it. It's not that hard. You just need some practice. You can get into those things. Since the movie is not playing, I'm going to move on, guys. And so this was angioplasty, and the flow was established, as you can see here. Balloons, I prefer over the wire because you have more pushability, and you can exchange wires. If that wire mangles up when you're advancing it and you need to change it, you can change it. If you're on a monorail, you cannot. And you don't have the same pushability. Tapered balloons, things of that sort are useful, we know. Now, one thing we've learned, or personally I've learned through making a lot of mistakes, that when I got to the foot down here, I used to undersize the balloons. I was afraid of using 2.5 balloons. You look at those vessels and you say, I don't think this is going to take it. You know something, when you undersize your balloons, the recoil will probably close that vessel before the angiogram is done.
I guess we'll just have
A couple of years ago, as I mentioned to you, we were using, our philosophy was multiple vessel revascularizations below the knee. So when you revascularize the anterior tibial artery and everything was good, then we would spend half an hour to do the posterior tibial artery. When you do repeat angiogram, we would see that the anterior tibial artery looks very different in just half an hour. And so we did a study, and we found that 18% of the patients, within an hour of below-the-knee interventions, if you're doing balloons alone, that vessel recoils and closes within an hour. Okay? So that 50 or 55% restenosis rate that is quoted and we see in the literature, about 20% of that is up front. It's just that none of us hang around for an hour to do an angiogram again. We just do it, it looks good, we let it go. So we did actually a meta-analysis of the literature before this is also in publication, to look at the early failures, and I'll show you the results. But here's a case of undersizing that I mentioned to you. So same thing, as you can see, the anterior tibial sort of not doing so well. Posterior tibial is occluded down here, but we have a lateral plantar reconstitution. This was recanalized, and here's another movie that's probably not going to play, so I move on. And as you can see in the image on the right side, my support catheter is in the distal lateral plantar artery with very good flow to the toes and the foot. Very good. So we angioplasted that. Now this is a 2-millimeter balloon. As you can see, if you guys could see the calcification, you can see the calcification around that artery is larger than my balloon. This is clearly undersized, And these recoil. Now this looks pretty good here, but this actually recoiled very quickly within an hour. So we went to cannulate the anterior tibial artery and the dorsalis pedis in this patient to connect this point to that point because this arch just wasn't good and I wanted to get good flow. By the time we were done, this lateral plantar artery and distal posterior tibial occluded. So we went and put in a 2.5 balloon, and we actually the next day had very good Doppler flow, and the patient healed. And here's showing the recanalization of this anterior tibial artery, which is not going to show. Stents, there are multiple available. In the literature, if you look at the drug-eluting stents, they've done better than angioplasty alone. This is the result of our meta-analysis that is in publication in JVS, showing that different modalities from angioplasty to atherectomy to bare metal stents and what have you, as you can see, up to 10% even failure at 30 days in these patients. My guess is a lot of these were failures within 24 hours. Debulking devices, multiple. Dr. Schmidt talked about these. This Phoenix one is the last one entering into the market by Astromed. It's actually an interesting one. For us, it's an enabling device. We don't use it as a primary therapeutic method. It's an enabling device. Just means if I'm stuck someplace, nothing else is working, we pull at that. For example, such as this patient, 74-year-old, non-healing ulceration. Here's what the angiogram looks like. You saw this angiogram already before. Now, as you can see on the right-hand side, I have crossed a wire across into the perineal artery, and that's a coronary balloon coming right behind it. And we cannot advance it. It's stuck inside all of those dense calcifications. We just could not advance it. So we used an atherectomy. So when I was looking at this, I said, my God, I couldn't get a 2 French coronary balloon across this. How's this going to go through? But 5 minutes later, we're all the way through. And this is what it looks like. Okay? So then, obviously, double wire technique, and the anterior tibial artery was also treated. Here's the difference. Look at the image on the right side. The perineal artery was treated with atherectomy and angioplasty. The anterior tibial artery was treated with angioplasty only. And that's the difference. This is where we use atherectomy, as I mentioned, in terms of enabling devices in these types of situations. Obviously, the patient did well. Okay, in conclusion, Endo first is the strategy of choice for below-the-knee revascularizations because it really does not close your options to the surgery behind that. Toolbox is critical to both acute success and improved clinical outcome over the long term. And devices for the treatment of CLI are improving every day because it's now a focus. And thorough familiarity with these devices is important in your success. My suggestion to you is if you have a robust CLI practice, you probably are familiar with it. If not, move on from one device to another. Most of us sort of get comfortable with one thing and stay with it. Then you never experience alternatives, and you don't know what to use those for. I stop right there. Thank you.